Okay, well, we're going to open this for discussion, so I invite anybody from the audience to get up to the microphone and ask your questions. And while some of you are getting up, let me start by asking Gebrine. So give us a bit of a sense of two things. One is, what is the proportion of your ROSs where you're actually putting the autograft in a Dacron graft? What proportion? And which are your real indicators? Because you showed a couple of examples. When we see the video, we would assume, people will leave with the impression Gebrine does all his ROSs inside the Dacron graft, so I'm going to do like him. But I know you're selective, so what proportion of the patients? And secondly, what I want to hear from you is, through doing these techniques, what are the potential pitfalls or complications or issues that you've encountered? Because it cannot be just as simple as 1, 2, 3 like you showed on the video.
For the first question, we have around now 112, I think, the last review, and out of around 700 cases. So it is, let's say, 15%, or something like that. So it is really very selective technique, let's say, for some patients when we have a risk factor for further dilation or prolapse or whatever later. So what bicuspid, regurgitant, or some redo. And we didn't talk a lot about it. Some redo patients, mainly homograft or whatever, when you really resect everything, you have a very big gap. And it is very difficult to fill that with autograft. Whatever you do, even the technique he showed us about the external stabilization, if you look closely to this external stabilization, you have 1 centimeter between this band, Dacron band, and the autograft. So I think in some patients at risk, or do bend up. But if you want to do ROS operation, I think it should be protected. And so it's really very, very limited. Now, for the complications, I haven't time. We have a 4 redo on 112. We have 4 redo. The first 3-1 was technical problem. And the technical problem was on the left cusp, because the left cusp was hitting a small part of the Dacron, because the orifice was not protected. So for why we use now, and we describe this technique, the tongue technique is really having the autograft covering the hole of the valsalva. It is to say that we cannot see from inside any prosthesis. That's really...
We have a question over here.
Yeah. So, first of all, I'm cardiologist. I'm not cardiac surgeon. So, I have one comment and 2 quick questions. I'm doing intra-op T for Dr. David for many, many years, so I know his cases. My first comment is about the cases that you showed as a residual AI in the OR. The last case had more than mild AI, mixed AI, and that was immediate post-op. That's the AI that will stay with the patient next week. So I don't think if I was there as an intra-op echo person, I would accept that last case. Because also AI decreased at the end of like a half hour after the operation. But if you do not control the blood pressure of this patient very well, that AI will come back. This is my comment. But my question about selection of the patient, because I'm involved in selection of the patient. First of all, I want to know how much reliable is the CT to measure the pulmonary annulus as a pre-op, because pulmonic valve is highly flexible valve and highly dynamic valve. I think CT doesn't have that temporal resolution to measure it very well. And my second question is about mismatch. We have many papers with Dr. David about the mismatch of the size of the pulmonary annulus and the aortic annulus. I know that if the aortic annulus is bigger than pulmonary annulus, that's the case in most of the AS patients. You can put the pulmonic valve as a root replacement and predicate a little bit the annulus.
Okay, got it.
What about if the pulmonary annulus is bigger?
Yeah. I got it.
Yeah.
Okay. So, Jordan, the 2 questions are fundamental, which is, the first one is, how do you measure your pulmonary annulus, and what do you think is the best method? And secondly, and we can get some comments from other people, is what do you do when you start having discrepancies? What is a 2 millimeter discrepancy? What do you do? What is a 4 millimeter discrepancy? Like, what's your algorithm?
Well, first of all, I don't think it can be measured within a 2 millimeter accuracy. I think you have to recognize that a couple of millimeters are going to vary by measurement methodology. I think a gated CT scan with both systolic and diastolic phases is the best way to measure it in terms of the preoperative planning, and I find it to be very accurate. The shape of the annulus of the two annuli are very different often, particularly if you have a Seaver-0 bicuspid valve. And then in the OR, I just use confirmatory measures to confirm what I've already checked using Hager dilators.
All right, so you're using gated CTA as your number one. What do you use? Gated CTA gets two votes.
For the pulmonary, nothing. It's useless. You will never get the proper, and I tell everybody, I get this call several times, you know, the aortic is measured at 29 and they measured the pulmonary at 17. Never. Do you think we can do the Ross or not? It is never 17, never rely on MRI or CT or echo. They always get it wrong. And the mismatch is never more than 5 to 6, and it can always be addressed with an annuloplasty.
I agree. We have 2 votes for CT, and we have 1 vote for my own brain. Does mine here is CMR? I use CMR. What do you use? Your brain.
What do you use to measure? Do you measure?
I don't know, I never measure. No.
Okay, so he uses his brain too.
I don't care about that.
This gets into Maral's last slide, which is the right brain versus the left brain. Okay, I love it. And Bert, you do the same thing that Ismail does.
I mean, the only thing I measure is to choose the diameter of the graft. I choose the diameter, the sinotubular junction of the pulmonary valve. It gives me an idea about in which diameter this autograft will be happy.
All right, listen, let's get to his question now. So the second part of his question is, what do you do with a mismatch? So, okay, let's just put it out there. You have a 5 millimeter mismatch. What do you do?
That you would address it with an annuloplasty. So systematically in patients that have AI with the dilated annulus, we're obviously putting a annuloplasty band to reduce the annular dimension. But in any cases of mismatch, even if it's aortic stenosis primary, which I would say is very rare, but if there's any mismatch, that's when we'd also employ an annuloplasty reduction ring, and that typically takes care of any mismatch, because as you said, the preoperative measurement is very unreliable, and you can see it's usually a lot closer than you think.
All right, we got to take the prerogative of the moderator because we got a lot of questions. Eric.
You don't need MRI, you don't need a CAT scan before, not for the annulus. You take the pulmonary out, you take a Hager's dilator, and go gently through the sinotubular junction. You as a surgeon know how to measure sinotubular junction. So if it's 19 millimeter, the annulus should be 10 to 20% larger. If it's more than 20% larger, you're going to have AI. Most you can't be sure of AI. So I love your presentation, by the way, where you're measuring in hextant in 6 parts. But in addition to measure the way he measured, there's one more variable. The degree of scalloping must be maintained. So it'd be interesting to develop some models that not only divided the pulmonary autograft in a third, but also how scalloping should make your suture line.
Yeah, we need
to prevent all the complications. You guys saw it.
But we need to standardize these techniques. So I'm with Jordan. Eric.
These were really great presentations, everyone, and particularly Bert, teaching us how to handle that little bit of AI, the eccentric, and that was really cool. Thank you so much, all of you. Gebrine, you just answered the question about sizing, so I only have one other question. Jordan, that tongue that you leave on the non-coronary sinus, I didn't quite get a sense. What do you do with it? Do you include it in your suture line? Do you tack it up, or does it just sort of sit there? What happens with that?
Yeah, I mean, I only do that if I'm doing an annuloplasty, but at the end, when everything's dry and I'm happy, I just put that on a little tension and I tack it to the interposition graft. I don't know that does anything of value. Chris could talk about his shawl, and there's some other things, but I don't think it hurts. If anybody feels differently, I'd love to learn.
Cool.
But that's what I do. And the one quick comment about sizing, if you're Tirone David or Gebrine El-Khoury, or you don't need to size things, you don't need to measure things, because you guys have different eyes than I do, and I've struggled a lot in my first 4 years of practice with screwing up operations that I learned from all of you, because it's not systematic enough. And so I'm on a little bit of a quest to make this systematic for people that don't have your experience.
So within 2 years, you will stop sizing.
Well, I'd like to tell you a history. By 1985, I went to a meeting on live-in surgery in San Diego, California. And there was Dr. Ross and Dr. Mark O'Brien from the Brisbane Hospital of Australia. And then I was excited about the results of this operation. And it is almost 40 years before. And then when I go back to Brazil, I made the first Ross operation for Latin America. And it was fantastic. 40 years after, this patient is fine with a reconstruction of the pulmonary artery with a pericardium tube I have made during the surgery because we didn't have homograft. This is a proof of less money, not science. And then this patient is okay until now. And then, in the 10th patient I have operated, it was a 15 years old man, and he died in the room operation. And I stayed for 5 years more without making any Ross operation, and then we go back doing it. But this is what I want to say to people, to the young surgeons. I don't know whether we still have young surgeons here. Anyway, if we should do for the patient what we think it's the best for the patient and the best you can do. If you think that the plastic or mitroplastic surgery is not well done, don't do it. If you think you don't succeed making a Ross operation, as doctors showed me yesterday in Petermann Hospital, so right and so fast surgery, don't do it.
Thank you.
Just wait. Okay?
Okay.
It's
Thank you. Laurent. Sorry. Bill.
Will Frank, I'm a resident at Cleveland Clinic and interested in aortic valve surgery and the Ross procedure, and great talks. I am curious about autograft reimplantation, especially as the indications expand and we're starting to put annuloplasty bands in these autografts. Can you give some technical pearls about, reimplanting the autograft for a reoperation?
You mean doing a valve sparing in the autograft as a second
Yes.
operation?
Yeah.
Sure. Gebrine, why don't you
Especially when
talk
there's
about it?
prosthetic material
The
now.
question is valve.
Is it valve sparing after the Ross?
Yeah. I mean, the only difficulty, I had with this preserving the valve, the autograft, years after, is years ago, at the beginning of our experience, we used to put a pericardial band around the autograft, and that awful became calcium. Became like this one.
Yeah, I've done a lot.
We have to spend time to take this one. It's possible, but sometimes you have a hole below the valve or whatever. I have many videos. Next time I will show you those videos. But it is possible. It's possible to save this valve.
I think there's two things really. Number one, the reimplantation is actually pretty easy because the Ross is up higher, so that's not the issue. Really, it's about one thing. It's about the leaflets. If the leaflets have short geometric heights, you can't do it. If they have good geometric heights, you can do it. It's almost that simple.
So I think you're asking, Will, if an annuloplasty ring was placed in the first operation, how does that affect doing a valve sparing? And my answer to you is, when you do the annuloplasty ring, you're actually stabilizing the annulus very effectively. And we have data now into the second decade showing flat annular dimensions. Maral showed some of that data. So I think when these patients come back, if they have a root dilatation, it becomes a simple remodeling procedure because if you already stabilized your basal ring with that annuloplasty. So it actually helps not having to dig that deep during the second operation.
But the problem is if there is aortic regurgitation associated to the ring, that's really became difficult.
No, of course, yeah. You always, the evaluation of whether it's sparable or not, that's a separate conversation. But if the root is dilated and you think you can spare, then the annuloplasty ring will not hinder. In fact, it will help your valve sparing. Laurent?
Thank you.
Yeah. Thank you for those very nice presentation. I really appreciate your honesty in showing your difficult cases because we are all facing that. And I really learn in looking at that. And I would like to know if you detect some things in your techniques that may have induced that, because we all are doing that on a frequently, and then you say, why today I have this eccentric or commissural? And I wonder if the eccentric is because of the level of the proximal suture line, and the commissural is about the annulus, the residual, the annulus size. Did you have this type of explanation maybe to those very annoying residual AI?
Yeah, definitely very annoying. I think I don't have an answer for the commissural jet of AI. I still can't explain why these happen. The eccentric jet of AI, I have a better explanation, which I think is probably correct, and that is, I was fixated on the notion that the pulmonary valve is 120, 120, 120 in all cases. And I wasn't paying enough attention to the symmetry of the commissures on the pulmonary. So I was forcing it into a purely symmetrical position in the aortic valve. What I did notice over time is that the 12 or 13 cases that we had eccentric jet, it was always, except for one, the right coronary cusp that was prolapsing. The jet was always directed towards the mitral valve, which actually made our life simpler because you can zoom in on the right cusp as opposed to if it's going to the septum, you don't know if it's the left or the none. And when I started paying more attention to putting a freestyle sizer or whatever, something that has markers, you notice that there's always maybe a little bit, maybe a 10 degree or this or that. And the one sinus that's a little bit larger is the non-facing pulmonary sinus, which always ends up in the right coronary sinus position using the way I do the Ross. And so I think I'm reducing the intercommissural distance and perhaps inducing prolapse. Again, it's a fine minority of patients. It's less than 2%. But these are the patients where we're observing this. So every time now I obsessively look at the symmetry. Most of the time, the commissures correspond to the 120 degrees, but occasionally you'll have some asymmetry that is not easily visible. You do have cases where it's frank asymmetry, and that we obviously pay attention to in implanting. None of these were the patients that had the eccentric AI. So it's important. You know, I used to write and always say 120, 120, 120. It's actually not quite so true in probably 1 to 2% of the patients.
Can I have one short comment on this question? And your technique, I saw the videos. I think the scallop the proximal part of the autograft is not always a good idea, because you are trying to adapt the autograft to maybe well-opened interreflex triangle. And by doing this, you change a little bit the commercial configuration. I think you have to respect the integrity of the autograft. Adapt the aortic outflow to the autograft, but not your autograft to the outflow. I think it may explain a lot of commercial problems. So far, we see that we do some kind of subcommercial annuloplasty. You are trying to correct this scalloping. So I think it is not always a good idea.
Although I don't scallop quite so much anymore. I mean,
That's perfect.
It's been years that I haven't been scalloping. In the commissures, I just get the muscle out just to the white part of the, and so the sutures follow a wavelet, as I say, as opposed to a triangle. Munir, you had a question.
Just an opinion from the panel. You know, everyone has a step where they look at the pulmonic valve and they inspect and make a decision. So what's an unacceptable pulmonary autograft? My personal lesson learned was one early failure from a Ross because of multiple fenestrations. I'm curious how you think about that.
Why don't we run it down the panel? Bert, why don't you answer first?
I think it's not a totally black and white answer either, because it's going to depend on your patient and their other options that they have. Meaning, if it's a young woman who has a small annulus and her backup is a mechanical valve, she wants kids, you might accept a less perfect pulmonary valve. But the things that we see that are concerning are when you have large pericommissural fenestrations where the leaflet is essentially hanging on just a thread. The ones that are along the free edge aren't as concerning, but it's really the pericommissural fenestrations, and then it's a case-to-case basis.
I trust the echo guy. If there is no regurgitation of the pulmonary valve, I don't look for fenestration. The only thing I look at in quite all the patients, 57, 58, sometimes you have this muscle into the root. So in those patients, I don't like, because we are at the limit of the indication to do the rest operation. Now, one question is the bicuspid valve, because we have it, and Joe show us a bicuspid valve. I remember in 2001, I got guy come to me, he said, I know I have a bicuspid valve pulmonary, but I'd like you to do a ROS on me. So he signed paper, I did the ROS. And next year, in 2026, we will celebrate. I got an invitation last I lost him. I got an invitation from him that he wanted to celebrate his 25 years of well-functioning bicuspid valve on the... So, not trust your echocardiographer, and if you have a bicuspid, mainly type A, symmetrical, I think it's good.
So if more than 50% of the sinus is replaced by muscle, I reject it. I do my own echoes because I don't trust our echocardiographer, so I do an epicardial echo. It's the easiest thing in the world to do because you put your probe on the PA and you see something beautifully. So if I see pathology, like a commissural leak, and then I find a fenestration, I bail. But if I find fenestrations and the valve is working well, then I'm okay with it.
We have great echo, so I do trust the intra-op TEE and have a direct inspection. If the pulmonary valve is already leaking on the echo at a pressure of 30, I abandon. And then visually, if the fenestrations are large and really significant, then forget it. If they're tiny commissural, we'll use it.
Yeah, I thought fenestrations didn't exist before I went to New York, and we're seeing a lot of fenestrations, like massive fenestrations, with perfectly functional pulmonary valves. So it is important to examine these. I mean, I wish I could show the videos. It's not a small fenestration. It's half the leaflet is basically no tissue at all. And it's quite spectacular because you have zero pulmonary regurgitation. These patients have we have time for 2 very short questions, 1 minute each because we're already late.
Okay, I'll try to be quick. My name is Matt, one of the trainees at Western in London. My question is to the kind of future of ROS surgery. I mean, great long-term outcomes in expert centers, but my question is more from like a residency training perspective. Do you think there's any role for earlier involvement in trainees in terms of getting them more comfortable with the ROS procedure? I'm fortunate that we have ROS procedures at our center, but how do we train more surgeons to become comfortable?
Okay. Well, I have a second-year medical student, Bana, who's in all of my ROS operations and sees all our patients in clinic. I think there is a role to get involved as a resident, but you have to be a dedicated aortic surgeon and go somewhere to learn ROS, a high-volume center. Michael?
Brief comment. We have this obsession with wrapping the ROS in Dacron, and I think we're all obsessed about worrying about the future aneurysm when we should be more worried about the early AI. Putting in the autograft takes a lot of technical detail and a lot of attention to the symmetry and how you implant it. We're ignoring that at the cost of, well, if we shove it in a tube, it'll be the same as doing a Bentall, same as doing a freestyle. It's not the same. And I think we're going to compromise a lot of autograft function early if we just keep shoving all these things inside Dacron.
Yeah. Michael, thanks for the comment. Just a small point, if I may. Our congenital surgeons, a group of them have been putting it into Dacron, and they're reporting it. They've submitted the data to EACTS, and hopefully we'll be publishing it this year. At 20 years, the results are not very good. It's actually 30%. Autograft regurgitation at 10 years, and so they have now stopped doing it. So it'll be interesting to see. Gebrine, would love to see the comparison of your techniques. Not a lot of surgeons have used different techniques, so it would be interesting to see Dr. David's also the
other thing I want to say to the young man who just asked the question about trainees, I would say if you're starting a ROS program, the first 30 or 40 ROSs, you always do with 2 heart surgeons completely, no questions asked. All right, well, this is a great session. We went over time, lots of yeah, but they have to leave, right? Yeah, the panel's gone.
Still running.
Someone needs to stay.